Welcome back. I am a medical doctor taking care of critically ill patients with COVID-19 with a successful management of them in the intensive care unit. This is the 5th video out of 10 of COVID-19 series. Welcome to the Medicine Essentials. In this video I will be talking about COVID-19 diagnosis, only viral detection strategies. For case definition, laboratory findings, radiology. Go to the video. COVID-19, clinical features. Polymerase chain reaction, RT-PCR. SARS-CoV-2 RNA is detected by polymerase chain reaction. Current recommended diagnostic modality for COVID-19. Results are generally available within a few hours to 2 days. A single positive test should be confirmed by a second RT-PCR assay targeting a different SARS-CoV-2 gene. If initial testing is negative, but the suspicion for COVID-19 remains, the World Health Organization recommends resampling and testing from multiple respiratory tract sites. For safety reasons, specimens from a patient with suspected or documented COVID-19 should not be submitted for viral culture. Samples should also be tested for other viral or bacterial pathogens. Recommendations for sample collection. Collection of specimens to test for SARS-CoV-2 from the upper respiratory tract, nasopharyngeal and oropharyngeal swab, is the preferred method for diagnosis. Induction of sputum collection is not recommended. Bronchoscopy, being an aerosol-generating procedure, has got the potential to transmit infection to others. In view of this, preferably avoid performing it, and limit its usage. Clearing secretions/mucus plugs in intubated patients. All respiratory specimen collection procedures should be done in negative pressure rooms. Additional specimens, e.g., blood, stool, urine, can also be collected to rule out alternative or supportive diagnosis. COVID-19 rapid test. COVID-19 rapid test qualitatively detects immunoglobulin G and immunoglobulin M antibodies to SARS-CoV-2 in human whole blood, serum, and plasma samples. This test applies lateral flow immunochromatography and is a tool to assist in the diagnosis of SARS-CoV-2 infections. The immunoglobulin G and M combined assay has better utility and sensitivity compared with a single immunoglobulin G and M test. It can be used for the rapid screening of SARS-CoV-2 carriers, symptomatic or asymptomatic, in hospitals, clinics, and test laboratories. The rapid test is performed as follows. 1. Place the cassette on level surface at room temperature, 15 to 25 degrees Celsius, or 59 to 77 degrees Fahrenheit. 2. Wash hands thoroughly with soap and water to ensure fingertips are clean and dry. 3. Puncture one finger using the lancet. 4. Use a clean paper towel or similar material to wipe off the first drop of blood. 5. Gently massage the finger from knuckle to fingertip to allow a second drop of blood to form. 6. Add 2 drops of blood, using the pipette provided, into the cassette well directly above the arrow. 7. Add 3 drops of buffer, using the same pipette, into the well. 8. Wait 10 minutes. 9. Read the results. Here is the interpretation for rapid test. On the image are shown 3 lines: the quality control line, the immunoglobulin G line, and the immunoglobulin M line. For a positive test we have 3 options. 1. The 3 lines appear. 2. The quality control line and the immunoglobulin G line appear. 3. The quality control line and the immunoglobulin M line appear. The result is negative when only the quality control line appears. The test have failed when the quality control line doesn't appear. I have left bronchoscopy in this video because there are some important points that have to be discussed. Let's begin with the benefits. Bronchoscopy helps in obtaining bronchoalveolar lavage samples in patients who are not able to expectorate sputum for checking bacterial culture, acid-fast bacilli smear and GeneXpert. Bronchoscope can be used to clear out mucus plugs in ventilated patients. We know bronchoscopy has its benefits, but the risks are higher. 1. It may cause some deterioration in clinical condition, especially in patients who are on high oxygen support. 2. High risk of transmission of infection to providers. 3. Significant utilization of valuable resources at this point, and 95 respirators, physicians, respiratory therapists. Supply of all these resources will be limited during the time of a pandemic. If bronchoscopy are going to be performed, here are the recommendations for its use. Bronchoscopy should not be done only for the purpose of ruling COVID-19. Risk of transmission of infection to others is extremely high through aerosols. It can be performed when sputum sample cannot be obtained to rule out alternative diagnosis, like tuberculosis, bacterial or fungal pneumonias. It can be performed to suction out mucus plugs in ventilated patients. Consideration for use of a disposable bronchoscope, if available. Consider bronchoscopy in patient's place of care to minimize the exposure. Minimize staff in room during procedure. Negative pressure room if available. All personal protective equipment should be used, face shield or goggles, N95 mask, contact isolation gown, gloves. Standard disinfection protocols should be followed for cleaning your flexible bronchoscopes and video monitors. Thanks for watching. This is just half of the videos. There are 5 more to watch. Next video, COVID-19 comorbidity and mortality.